I'm Josh McDonald.
And I'm Randa Materi, and we are Hand Therapy Academy.
Let's chat a little bit about types of distal radius fractures. A lot of times you get the patient in and you don't always know exactly what type of fracture they had, how the bone was repaired. We don't always get op reports in as much as we'd like to, or we just get, volar plate placed, but we don't know maybe what type of fracture it was. So let's kind of review our types. We've got Smith and Colley's fracture, probably our most common that we'll see more often than not. A Colley's fracture is a dorsal displacement of the head of the radius. So that's like a fallen out stretched hand. That's the most common one. And I can remember Colley's starts with a C and common starts with a C. So the most common, you fall an outstretched hand and it pushes that distal end of the radius dorsally. Smith's fracture, you fall on the back of the hand and that pushes that distal end of the radius volarly. And so that one's a little less common because you're falling, but dog trips you on a leash or something, you may fall on that hand if it gets caught underneath you. We've got Barton's fracture, where it is the it is the volar lip of the radius that fractures off. You can have a reverse Barton's, which is obviously just the dorsal side, but Barton's is that volar aspect, that volar lip fractures off. A chauffeur's fracture, or man, help me out. It's Hutchinson's.
Hutchinson's, yeah, or
Hutchinson's
radial styloid.
Yes, and that's where that whole radial styloid drops off on the radial aspect, and then die punch is where the lunate gets pushed down axially and kind of creates this punch effect of the distal articular surface of that radius drops down in kind of a axial load compression.
Okay, so just for clarification, your Hutchinson's, radial styloid, and chauffeur's fracture are all the same, and
Yes.
then die punch is another category.
Correct. Yes. Sorry. Die punch is a whole different kind, and that's like a singular part drops down into that shaft because it gets shot down, almost like a machine die punch, just punches something straight down.
Right. And so, do you think it matters if we know the type of fracture and why? Like, why do we even care?
That's a good question. Sometimes we like to have way more detail in hand therapy than we actually need. Like you can help the patient just fine without knowing all that information, but it does give me some window into potential outcomes. So if I know a patient had let's say a Colles fracture, and as a result of that, they had some misalignment of that volar tilt that's supposed to be 22 degrees. And because it shifted, it is now too tilted. Or maybe with a Smith's fracture, it is not tilted enough. That will impact their ability to regain wrist range of motion towards that missing angle.
Yeah. So, and then I think, like for myself, I think it's good to know, like for instance, like chauffeur's fracture. So, chauffeur's fracture is basically named after, in the old days when the chauffeurs had to crank the cars, the car crank in the front, a lot of times they would miss and hit their radial styloid and it'd break off. That's why it's called a chauffeur's fracture. So, with that type of fracture, it lines up with the scapholunate interval a lot of times. So they are more likely to have a scapholunate injury as well. So I think if we kind of know these common type problems that could occur along with it, then we're more aware, right? So we're like, oh, maybe this patient does have a little bit of scapholunate problem. So I'm going to avoid working the ECU too hard, especially when we're in this early healing phase. So I think, it's powerful to know. Do we have to know every detail? Probably, probably not, right?
Yeah, yeah. But you're right too. Patients will have questions about like, hey, why does my wrist hurt over here? Or why does it bug me on this side? Well, if I know they had a chauffeur or Hutchinson fracture, and that's where the fracture was, they just think I broke my wrist, but I can show them a picture of that. And we can talk about maybe where their hardware is likely placed and give them more education and more comfort with their diagnosis so they can have that understanding. There is peace in that knowledge of them saying like, okay, now I understand why it hurts there. And so it's not this big mysterious thing.
Right. And then I also think I know early on you talked about a Colles fracture being a dorsal displacement. So the dorsal or the distal part of the radius moves dorsally. But then also I like to tell them like, well, this piece goes dorsally, but then you have volar angulation,
Mm-hmm.
right? So if it's not like perfectly restored, you can be like, well, this is why that might look like that, or if they didn't have surgery, right? A lot of these patients will be like, oh, I'm not getting surgery. They're afraid, so they go. And then
Yeah.
you're like, okay, well, that is probably why you have this wrist that looks like that, and you can explain it to them.
And it's unfortunately probably too late by the time they get to us to have done anything different about the surgery. But some of our patients aren't candidates for surgery. They have other comorbidities, they have other problems going on. They're old and just not fantastic candidates for anesthesia and going under for things. And so I've seen patients who were just casted and they do not look fantastic coming out. I've got a patient now who couldn't have surgery and she's got some massive swelling on the ulnar side of the wrist. Doctor says fracture's healed, go to therapy and do whatever. And she's like, I'm not doing anything with you guys. Like, this isn't like, I need to be careful. And so we have to slowly work them into that. But knowing what kind of fracture maybe helps me understand. Maybe it's something on the ulnar side of the wrist is being impinged, or, we gave her a wrist widget and that seemed to fix 40% of her problems on the ulnar side of the wrist. So knowing the mechanism of injury and the type of fracture with surgery or not can give us a lot of information to help the patient understand what's going on.
Yeah, the complication. And then another complication of these distal radius fractures is carpal tunnel, right? Carpal tunnel syndrome. So are the docs you working with, are they releasing the carpal tunnel when they go in to put the plate on? What type of complications are you seeing after that, or not? Or kind of what do you see in your clinic after a distal radius fracture?
As far as carpal tunnel releases, I feel like it's 50-50. And it depends on the doctors. Some of my doctors, all of them will do a carpal tunnel release while they're in there, and others, they don't ever do it. And I feel like if I had a distal radius fracture, I would ask for that because I think I'm going to have swelling, I'm going to have edema, I'm going to have scar tissue buildup probably around plates and such. So let's just go ahead and do that proactively. There's very little downside to that. While you're in there, it's not like endoscopic where there's a risk of did you get it all or not. Everything's wide open. Go for it.
Yeah, I think that's exactly what I'd say too. Please release it.
Yeah, yeah. And if they didn't, or if they're a non-operative patient, then you've got to worry about sensibility, and you've got to worry about, if there's median nerve compression, even ulnar nerve compression if they've got that ulnar-sided wrist pain.
Yeah, that's true too. And then, if they do have it, then they're like, oh, great, you have to go back to the operating room to do the carpal tunnel release, or maybe even an injection then, right? And
Yeah,
then the injections are painful. Like I've gone to patients' visits where they've gotten those, and I'm like, oh, that hurts.
yeah, yeah, yeah. I feel like, and we've done another podcast on injections. I try to avoid the concepts of injections for patients as much as possible. It's just not pleasant. It stinks. Yeah,
But then I feel like there's some where you're like, yeah, that was a good outcome from it. So
yeah, yeah,
yeah.
yeah. So as far as splinting, do you do any different kinds of splinting if you have a patient with different types of fractures, or is it kind of our standard ulnar-based wrist support, regardless of the nature of the type of distal radius fracture?
Yeah, I do, like, if it's comminuted and they didn't have surgery, then of course I might not do that. I might do something more of a clamshell that's more like a cast. But I feel like those patients get casted anyway, so we don't really see them that much. But if they refuse a cast or something, that might be an option. But for the most part, I'm doing pretty much the same thing that I
Yeah,
would, for all the different types. How about you?
pretty much the same. I honestly get so rarely with the surgeons that I get patients from, so rarely do I get a thorough op report or visit note that a lot of times it's just a referral that says DRF on it. And so I'm kind of left with, unless I know it was a non-operative patient and we have to really lock them down and then a clamshell. Otherwise, I'm doing the less bulky ulnar-based 16th inch material for an ulnar-based wrist support, and it had good success with it without having to get too bulky.
Yeah. And then I think it depends. If they have a plate and I know they have stable fixation, I'm going to do something really light that's just comfortable for the patient. If they don't have stable fixation, then probably something a little more rigid. And I will say, I like, at least for us, this is probably the most common diagnosis we see. So I think, as I always tell students, learn how to do this. You'll probably see it, even if you're not in a hand therapy clinic, you're going to see it somewhere.
Yeah, yeah. If you're doing home health, you're going to see someone who fell and has a distal radius fracture. It's just the nature of our aging population.
Yeah, if you're in the hospital, you're going to see them, show them tendon glides, make sure their shoulder doesn't get stiff. Yeah, this is like a service you can do for, pretty much in a lot of aspects of OT.
Yeah, yeah. All right. Hopefully that's helpful for you guys, learning a little bit about the types of distal radius fractures. If you're interested, we do have a course all about distal radius fractures, kind of an introductory soup to nuts conversation on all the distal radius fracture stuff. You can reach out to us via email, info@handtherapyacademy.com, or on our social media platforms with the handle Hand Therapy Academy.